All right, so I understand that Director Wallace will not be joining us this evening. So I think everybody else is here. Is it okay if we go and get started? Call this meeting to order. If you're able, please stand and join me in the Pledge of Allegiance. I pledge allegiance
to the flag
of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you.
For me, that pledge is taking more and more significance with all that's going on in the world. All right, roll call, please, Dee.
Director Yee.
Present.
Director Stewart.
Present.
Director Wallace. Director Epen.
Present.
Director Nicholson.
Present.
Very good, thank you. And who else is in the room with you? We'll add them in.
Kimberly Hartz, Chris Henry, Tina Nunez, Paul Kozachenko, Shri Badu, and me, D'Antonio.
Okay, very good. Thank you very much. Well, welcome to the March 9, 2022 regular meeting of the Washington Township Healthcare District Board of Directors to continue to protect the health and safety of the members of the board, district staff, and members of the public from the dangers posed by SARS-CoV-2 virus. The Brown Act allows a local agency to continue to hold its meetings remotely as opposed to being required to meet in person. Section 54953E3 of the Government Code requires that the board make certain findings every 30 days to continue meeting remotely. One such finding is that, quote, state or local officials continue to impose or recommend measures to promote social distancing. The Alameda County Health Officer continues to recommend social distancing and the wearing of masks indoors. I refer the public to the Alameda County Healthcare Services Public Health Department COVID-19 website at www.covid-19.acgov.org. And now I ask for a motion that the board make the finding required by section 54953E3B2 of the Government Code that quote, state or local officials continue to impose or recommend measures to promote social distancing, end quote.
Madam President, I make the motion that the board make the findings required by section 54953E3B2 of the Government Code that's state or local officials continue to impose or recommend measures to promote social distancing.
Very good. Is there a second?
Second.
Thank you, Dr. Nicholson. Roll call, please, Dee.
Director Yee.
Aye.
Director Stewart.
Aye.
Director Wallace. Director Epen.
Aye.
Director Nicholson.
Aye.
Very good, thank you. Public notice for this meeting, including dial-in information, has been posted appropriately on our website. Tonight's meeting will be conducted by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Okay, moving on to communications. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? None? All right, Dee, is there any written communication?
There are not.
Okay, thank you. Well, we will move on to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion, unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Does any member of the public want to remove an agenda item from the consent calendar? All right, hearing none, may I have a motion to approve the consent calendar item A?
Item A, in accordance with the district law policies and procedures, I hereby move that we hold off placing the tax measures.
Oh, wait, no, I'm sorry. We're on the consent calendar.
Oh, in accordance with the district law policies and procedures, I move that the board of directors approve the consent calendar items.
Item A. Thank you. Is there a second?
Second.
Thank you, Dr. Nicholson. Roll call, please.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace, Director Eapen,
Aye.
Director Nicholson.
Aye.
Okay, very good. Thank you very much. All right, next are presentations. Kimberly, would you like to please introduce these next two presentations for us?
Yes, I'm going to start with first our presentation that is going to be by Dr. Jackie Chu. She's the medical director of the Washington Prenatal Diagnostic Center. And I'm just going to give you a short bio on Dr. Chu. She's a perinatologist and professor of medicine at UCSF in the Department of Obstetrics, Gynecology, and Reproductive Science. She is board certified in obstetrics and gynecology with a subspecialty in maternal fetal medicine. Dr. Chu earned a Bachelor of Science, cum laude, in biology from Union College, Schenectady, New York, and then received her medical degree from State University of New York, Syracuse College of Medicine. She completed a residency in obstetrics and gynecology at the Milton Hershey Medical Center at the Pennsylvania State University. She finished her training with fellowships in maternal fetal health at Rush Presbyterian St. Luke's Medical Center in Chicago, and in advanced fetal ultrasound and invasive procedures at University of Colorado School of Medicine in Denver. It is my pleasure to introduce her, and I think everyone will enjoy her presentation, which is the Washington Prenatal Diagnostic Center, a model for the successful collaboration of academia and community. Thank you, Dr. Chu.
Thank you so much, Kimberly. Let me go ahead and screen share here. Please just let me know when you're actually able to see my desktop here.
Yes, we can see it.
Great. I'm going to try and put this on slideshow for us. Did that work?
Yep.
Excellent.
Yes.
All righty. Well,
You're a pro.
2 years into it, we'll see how this luck keeps going here as far as this goes. Thank you. I'd really like to thank you, Kimberly, and also to all the members of the board for this invitation. For me, just to talk a little bit about our developments in the Prenatal Diagnostic Center. As many of you already know, we established our center in 2017. I'll just pick up a little bit where I left off last time. This was part of the strategic vision of the Washington administration to provide state-of-the-art medical services in our local community. Our mission, therefore, is to bring the most advanced prenatal diagnostic care to our community and to support the Washington obstetric community by providing high-risk pregnancy care. So we opened in 2017. We spent the first few months designing our unit, building our infrastructure, recruiting our staff, and training. In 2019, we were able to achieve accreditation from the American Institute of Ultrasound and Medicine. We received recognition from the state of California genetic disease brands in order to perform prenatal screening. What services do we provide? We provide advanced 2 and 3D fetal ultrasound in order to evaluate the physical health and development of the fetus. We do Doppler flow studies, make sure that the supply chain of all the nutrients going to the baby is okay. Babies have to worry about that too, I suppose. We perform fetal echocardiography in order to detect defects of the heart, both structurally and functionally. We provide the full range of comprehensive genetic counseling and screening, invasive fetal testing, including amniocentesis and first trimester chorionic villus sampling for early diagnosis. We also provide high-risk pregnancy care for maternal diseases. We have a one-stop shopping concept in our unit where we can kind of launch and land certain issues, concerns that the patient has, hopefully in as much as just one office visit. We can, for example, start with an ultrasound exam, plug in our numbers into the state screening calculator, have our state screen results delivered in the same visit, move on to genetic counseling if needed, and even in the same day have blood testing and an invasive procedure performed should it become necessary. So how do we do? Our total PDC activity is on this graph. Currently, we're performing almost 3,000 billable procedures annually. We started with a pretty steep growth, and then COVID hit and we needed to scale back in order to minimize exposures to our patients. We were performing essential exams only. It's of course when we learned things like shelter in place and such terms. We converted part of our PDC into a station to perform the in-person components of a routine office clinic visit in order to support our Washington Township colleagues in their efforts to do telehealth. We would have the patient as a captive audience for an ultrasound and really try to coordinate with them for their visits. Once we had vaccines, we were able to inch back little by little and have our volume increase and meet our patients' needs with the appropriate safety measures in place. But of course, as we all know, COVID is sort of still with us, but I do think we're on the upswing and we'll have much brighter days ahead. In terms of our invasive procedures, this has continued to grow, and especially our referrals for chorionic villus sampling, our first trimester placental biopsies. We receive referrals from within our own community, as well as from PAMF in the South Bay, since we are the only center on the East Bay who performs these procedures, other than my UCSF colleagues over in Oakland. In terms of fetal echocardiography, so this is subspecialized exam of the fetal heart performed by a pediatric cardiologist from UCSF who comes to our unit. We are one of the only one of a handful of units in the whole country that offers on-site fetal echocardiography together with maternal fetal medicine. And this is a really beautiful patient-centered approach where a patient can undergo an echocardiogram and pediatric consultation in conjunction with maternal fetal medicine in one setting to have all of the information delivered and questions answered in real time rather than sort of in tandem one after another. So this curve follows the same sort of pattern for caseload, but it is on the upswing, and we've surpassed 100 echocardiograms in a year. And so this brings us model of collaboration that we have between Washington Hospital and the UCSF health system. And this model of collaboration is beautiful and has really allowed the PDC to thrive. And I'd like to take this opportunity to thank Kimberly and the entire hospital administration, as well as my own department at UCSF and the administration there, for the support, resource allocation, and flexibility to allow this model to be. So let's take a look for a moment at the two different kinds of centers that we're thinking about here. On the one hand, an academic medical center can be thought of as a medical product leader. We think of these centers as offering highly subspecialized services, procedures, treatments that require a lot of expertise. They attract professionals from all over the world. These are large centers that can be really difficult for a patient to navigate for the everyday types of care that they might need, and so might not always always be the first choice to meet the needs of ease of access and what have you. The community hospitals, on the other hand, tend to be patient experience leaders. Here, we can have a more holistic approach to the patient. We can provide personalized care, easier access, sound treatments for most of the things that a patient is going to need most of the time. So the challenge of collaboration then really is how to establish seamless communication and alignment between the systems so that optimal benefit can be obtained from both of these systems. So I'd like to demonstrate how this works by a few patient examples. Let's start with patient AS. She's a 25-year-old generally healthy woman in her first pregnancy with an anatomic survey at the usual time of 19 weeks that showed a nice normal female fetus. She was seen for another ultrasound at 34 weeks, and surprisingly, a large cyst was found in the fetal pelvis, which extended into the abdomen. So we have an abdominal pelvic cyst in a female fetus. And how do we make sense of this picture? Well, let's look at the diagram for a moment and get oriented. The baby is lying on her side. She's right side down, and the neck is over here, and the head is off the screen. We have the heart, the shoulders, the abdomen, and the hip. So the right side is down, so the liver is down, the stomach is up, it's on the left. We'll make the bladder yellow, that would be appropriate. And so what do we have left over? This is the structure that doesn't belong. This is the cyst that we're talking about here. So a 3 centimeter left-sided abdominal pelvic cyst in a female fetus. We'll kind of go down through the fire drill. We'll sort of describe it. It's round, thin-walled, etc. Where is it? It's anterior, it's below the stomach, it's above the bladder. Importantly, the intestines are normal without evidence of obstruction. It doesn't seem to be part of the urinary tract or the kidneys. It doesn't seem to be attached to the gallbladder. So when we see this pattern, it's very, very likely that this is an ovarian cyst in a female fetus. So we go, wait a second here. How can this be? Isn't ovarian activity, isn't it pretty quiet? And in childhood, we'd be right. The ovaries really don't do a lot. They don't wake up until puberty, and then they become cyclical every 28 days after that. But amazingly, during pregnancy, they can be pretty active. We can have reactivity from the hormones of pregnancy. And so it's not entirely uncommon to have a cyst in the female fetus during the pregnancy, during intrauterine life. So what can happen if we have an ovarian cyst? Well, ovaries tend to flop around. Normally, they're loosely held on a pedicle. And if there's a cyst that's sizable, that ovary can kind of be lopsided and get to going a little bit too fast and actually twist around its pedicle and cause obstruction of the blood flow to the cyst. And this is a picture of this in the OR. This isn't this patient, but here we've got the ovary, here we've got a cyst, and we have a twist in the pedicle. And this can cut off the blood supply to the ovary, and then we will have loss of the ovary entirely. And we wouldn't want that to happen. So what do we do? Well, there's no need for intervention in utero, but we sure do want to know about it so that we know to take care of it. After the baby is born, we can have confirmation neonatally. It's really important to be sure that we're right, rule out a bowel or liver pathology. And this is usually done, this assessment is done by pediatric radiology. But at Washington, we don't have pediatric radiology subspecialists because we're not a children's hospital. So what happens is these newborns typically are referred out before they're sent home. They're referred out to a facility for radiology workup. But the question is, well, can't we do better? Couldn't we scan our newborns here at Washington and maybe have our UCSF radiologists on board and kind of confirm our reading? Let the baby who's otherwise doing perfectly well just go home with mom and all of that happiness. Well, sure, of course we can. We thought we better bridge the gap. So had a little meeting with Dr. Pinar, a UCSF pediatric radiologist, had some meetings with Washington radiology. And then Stephanie Williams really helped us take this over the finish line. And she had what she loves to do, which is a beautiful collaboration of meeting of all stakeholders involved. Neonatology needs to know that we in MFM was suspected. We need to get the mom's medical record combined with the newborn's medical record. We need to include our own radiologists and the UCSF radiology as well. And we had IT support and identified as appropriate for use our already existing beautiful live image exchange network. So baby was born, did great, did an ultrasound right here at Washington Hospital, had gorgeous imaging, quite frankly. And here is this beautiful ovary with a cyst right here and the nice normal ovarian tissue down here. And this cyst actually had a daughter cyst, a tiny little cyst down here, which we don't have the resolution to see prenatally. And this is pretty pathognomonic. It must be an ovarian cyst. And so we were able to have the confirmation that we needed with our collaboration, and this baby went home. Unlike the baby who was born just months prior to this, before we had kind of this working relation set up, and that baby did go to Benioff Children's, part of UCSF, as was appropriate, because again, we needed to make sure that this wasn't belonging to some other organ system. So this baby will just get followed, and if there's any sign of torsion or any other trouble, it can be identified early, taken care of, and the baby doesn't have to lose that ovary. Switching gears on to the next case has to do with cesarean section, a patient that had a previous cesarean section. We all know that cesarean section rates rose in the United States between about 1989 and the early 2000s, just this huge increase. And through our professional bodies and a lot of work, there was a lot of work to try to stabilize the cesarean sections out. And we're now at a rate steady at about a third of all women will deliver by cesarean. But there's a reason why we wanted to have this stabilize out. These aren't without risk. One of the more rare complications that we can see of a prior cesarean section is rupture of the uterus. This is the uterus, and the suture line here, right at the finish of a cesarean section, it heals up, but it's simply not as strong as the uterine muscle before it had an incision. And so what can happen is the incision can split open, and the baby then can come on out and be extruded. And a lot of harm can come from this, demise, neurologic injury, let alone to the mom with operative injuries, infection, hemorrhage, blood loss, shock. So this is super, super rare. Just briefly, it occurs about 0.5% of laboring patients who have at least one prior cesarean delivery. 25% of the time, if this happens, results in death of the fetus or newborn. And of the survivors, a large chunk of them will have some neurological sequelae. An ultrasound can rarely demonstrate an impending rupture of the uterus because they occur almost exclusively at term. So this brings us then to our second patient, LM. She's 31 years old, healthy, has 2 cesarean deliveries, comes to see us at about 19 weeks, and surprise, there's this bleb of uterine, of amniotic fluid, part of the amniotic bag, pooching out of the uterus. This is the baby's head. This is the cervix. This is going to be the trap door, the way out someday, if this baby gets near term. Yet the amniotic sac is already protruding through the uterine scar. Just to give you an idea of how this is supposed to look, this is the fetal head, this is the cervix, this is the trap door. The way out will eventually open up at, normally during labor. And then this is our case where we have the cervix and the uterine wall, so the uterine wall over here, and there's this big bulge of amniotic cavity protruding through. This is what this looks like in real life. A case from years back at UCSF where we made a skin incision, saw the uterus, and didn't even have to make a uterine incision. It had already split apart, and you see the bulge of the amniotic sac coming out, and that's what we're seeing here in ultrasound. This is at term, this is at 19 weeks. So this little baby was a bit of a jokester, and I think most people can kind of recognize that's actually a hand. It's a little bit funny, but it's also quite scary because at this moment, the hand is actually outside the uterus. So it kind of poked the hand in and out, actually poked the foot in and out as well. And here she is at only 22 weeks and 6 days. She has a long way to go. So what did we do? Well, the patient was offered all options because of the high risk of uterine rupture, and she really wanted to continue the pregnancy. So we had a meeting, we have a meeting every week at UCSF where we present clinically complex patients. And so I presented her there, and we determined that she really should be hospitalized at UCSF. The last case we had, we hospitalized at 21 weeks. But we wanted to minimize the amount of time that she would spend away from her family. So we agreed that I would follow up with her every week with ultrasound until 28 weeks. And that's when the 3rd trimester starts and the uterus undergoes exponential expansion. And that we would get her in the hospital at that time and follow her more closely to an operating room should she need one. So she was seen every week, and whenever she had symptoms, I actually gave her my cell phone number, and she was just hospitalized 2 weeks ago at UCSF, and I went and saw her and did her scan there to give her continuity of care there, and she's still undelivered. She's about 30 weeks, almost 31 weeks at this point, and I think she's going to have a good outcome. And then our last patient, NG. 27 years old, first pregnancy, was found to have growth lagging. The growth was pretty poor. She presented to labor and delivery at 27 weeks with bleeding, contractions, preterm labor. Cervix was already dilated a centimeter. We said, oh my goodness, she's only 27 weeks. Our NICU can take care of preemies very nicely, but not this preemie. So we transferred her to UCSF. There we were able to see a clot behind the placenta. So we diagnosed a placental abruption, gave her steroids for maturity. The contractions petered out, the bleeding stopped. She became stable after about a week or so. We decided to send her home and have me follow up with her here in the PDC. I saw her at 29 weeks and she had a brand new problem. This is the same configuration that I showed you on the last case. This is the baby's head and this is the cervix. We can see this time the cervix is actually open. It's open a centimeter and the bag is protruding down through the cervix, but whoopsie daisy, what's coming down? The umbilical cord. This is a model where you see a similar thing and the cord is all the way out into the vagina. It's called a cord prolapse should this happen. So she's at risk for breaking her water and actually having this happen should she go into labor, or even if she doesn't, she can have spontaneous rupture because the membranes are exposed to the outside world into the vagina here. If this were to happen, the cord would be compressed and we would have a fetal demise. So I sent the patient straight to labor and delivery at Washington Hospital with a plan to transport her out to UCSF. She was transported back to UCSF, hung on to her for a few days. I got to go back up there, scan her again, and the cord slurped back up and was up into the uterine cavity, and she got to be sent home again. So 2 visits to UCSF and back and home in our ballpark. So I saw her at the PDC again at 32 weeks and 6 days. And what did I find? I found that the cord indeed was back down in front of the head. The difference here, though, is now she's so far along. Our NICU can handle this if the baby were born. Our obstetricians can do a delivery. Our nurses can can monitor this baby appropriately, call the doctor in a timely fashion, we can actually handle this. So we sent her to, I sent her from my office here back up to Washington, labor and delivery, where she was admitted to the antepartum unit. Over a few days, I hopped back over to the hospital, did an ultrasound, and indeed the cord slurped back up into the uterus where it belonged. And I got to send her home, and I watched her really often here in the PDC. Eventually the head got big enough, it filled the entire lower uterine segment. There was no more space for that cord to ever come back down again. She did great on all of her monitoring, was admitted at 37 weeks for labor induction. Was really easy to induce her. In just a couple of hours, she was delivered. And she had a small baby, because we knew the baby was restricted in growth, but a healthy baby at 5 pounds, 10 ounces, essentially. And so this was another just huge success story. So I'd like to conclude by saying, well, what can we draw from these examples? We had 3 examples of a successful collaboration between major academic center and a community hospital. The patients get to receive the best of both worlds. They get the advanced resources when needed, plus the continuity of care and a personalized approach of care within her own community close to home. We had different contributions by both institutions in all 3 cases, but we had a shared value system that ran as a single thread throughout, and that is, we do whatever's best for the patient. And so this collaborative model that we have together, it's based on the premise of UCSF faculty joining the continuum of inpatient and outpatient services within the local community, as opposed to being offset and having just a referral to a higher level of care. And the PDC, working in with the obstetrics group and the pediatric group, it's particularly complex because we have both inpatient and outpatient services. All of our outpatients eventually are going to become inpatient. All of our single patients are eventually going to become 2 patients. And so it's logistically quite challenging, but incredibly rewarding. We have easy access to the academic resources when needed. We have easy return to the community hospital as soon as it's feasible. It really works just beautifully. So with that, I'd like to thank everyone once again and take any questions that you might have. And I'll stop sharing.
Thank you, Dr. Chu. I'm just so thrilled that you are here taking care of our tiniest residents. And it's great to hear these happy outcomes. You had mentioned the fetal echocardiography, and you said we're one of a few. And how big of an area?
I think the whole nation.
The whole nation.
Oh yeah.
Oh my goodness. Boy, aren't we blessed? We are so blessed. Wow.
I just really am in love with this model, and I really wanted to have this.
Oh, well, that's so wonderful to know that that's right here, and you're there, and we have such a privilege to welcome these little ones.
Yeah, they're our youngest colleagues, aren't they?
They are. They're our hope for the future.
Yeah.
Thank you so much.
Well, I'm just thrilled to be here. I honestly am. It's wonderful. Thank you.
Good.
Okay.
Any other questions or comments from board members?
I would just say it's just wonderful to see this collaboration and to see the fluid communication between the UCSF and Washington, and also the ease of access for the patient between the resources available at each institution. Just a wonderful example. Thank you very much, Dr. Chu, for bringing this to us.
Well, thank you so much for the opportunity and really all the support that I've received. It's really just, it's an effort from everybody. So thank you.
Well, keep up the good work.
Thanks, absolutely. Thanks.
Thank you.
All righty then.
I had one question, Dr. Chu.
Oh, yes.
You know, the fetal medicine surgery has been advancing so much. In fact, I think the first successful fetal medical or medicine surgery was done in UCSF, I believe in early 1980s, 81 maybe.
That's exactly right, Harrison.
Yeah. So the question I have is, with a ruptured uterus, with all this advancement, can that be fixed?
Yes, it actually can be. And it's been done, in Texas, where there's a unit very similar to what we have with all the expertise there. And there's really no consensus in terms of what's best to try to fix it, to try to manage these conservatively. The vast majority have been managed conservatively. The largest series in the English-speaking literature that we've been able to find is 30 cases, maybe 27, something like that. This is incredibly rare, but if it's rare, it's going to happen at Washington. And we actually toyed with that idea of putting a mesh on this thing, but we thought she was doing so well at this point that the better part of valor was really to have a hands-off approach. But I love your thought, and I really thank you for that question.
Thank you. Thanks.
Thanks.
Very good. Great.
All right. You want me to go on and do the second presentation? Thank you, Dr. Chu, very much. We appreciate your passion and your support on the collaboration. And I think that you're integral to the success between the two organizations and this program. So thank you very much.
Absolutely.
Thank you.
Very good. All right, go ahead, Kimberly.
All right. Our next presentation is the plan of finance with our 2022 general obligation bonds, and I'm going to actually turn it over to Chris Henry, our CFO and Vice President, to introduce our guest this evening and talk a little bit about the presentation.
Okay, thanks, Kimberly. As we're all aware, in November 2020, the district residents generously approved Measure XX, which provided authority for Washington Hospital to issue up to $425 million in general obligation bonds. The bonds will finance new construction needed to fulfill state-mandated seismic requirements for earthquake safety. Tonight, we're here to discuss the first proposed issue of Measure XX bonds. The proposed issue would cover the construction costs of the Morris-Hyman Critical Care Pavilion Connecting Bridge and the pre-construction costs of the Morris-Hyman Critical Care Pavilion infill project. The infill project includes construction of 8 ORs, including 2 hybrid rooms, a new sterile processing space, new space for the pharmacy, and also for imaging. Leslie Wells, Gordon Howie, and Ed Wallab are here tonight to walk you through the proposed plan of finance. We're all familiar with them, but let me remind you a little bit of their credentials. Ed Wallab is the Vice President with the Healthcare Public Finance Group of B of A Securities, Inc. Ed has over 30 years of experience providing financing for a wide range of healthcare providers, and he has been with B of A Securities for over 18 years. Ed has served on the district's financing team since 2006 and has been involved in each of the district bond issues since then. Ed holds a BS degree in agricultural economics from UC Davis and an MBA from UC Berkeley. Gordon Howie is an independent financial consultant to nonprofit healthcare providers. Gordon works with healthcare systems and freestanding providers on financing programs and capital planning issues. Prior to becoming an independent consultant, Gordon worked for 31 years as a healthcare investment banker before retiring from that industry in 2008. He directed West Coast healthcare practices of Kidder Peabody and Company, First Boston Corporation, UBS Financial Services, and Bank of America Investment Services. During his investment career, banking career, he served as the principal client officer for many of the largest nonprofit healthcare systems across the country and a number of major acute care providers on the West Coast. He has worked as Washington Township's investment banker since beginning in 1992. Prior to his investment banking career, Gordon was a healthcare management consultant with Booz Allen in Hamilton. He holds a BA degree in economics and an MBA in finance from Harvard University. Lisa Lee Wells is a 1970 honors graduate of Wellesley College and took her JD from Stanford Law School in 1975. After serving on active duty with the Navy JAG Corps in San Francisco and at the Pentagon, she commenced a career in municipal finance with O'Melveny and Myers in Los Angeles in 1978. Since that time, she has focused on public finance and administration, assisting public agencies, nonprofit schools and hospitals, credit banks, and underwriters in the issuance of tax-exempt and taxable debt of all kinds. Ms. Wells has served as the Underwriters Counsel and consultant on our revenue bond issues as far back as 1991. So we clearly have the A-team here to talk to you tonight. So with that, I'll turn things over to Liesl as they walk you through the plan of finance.
Thank you so much, Madam President, members of the board. It's lovely to see you, even if it's virtual. It's been a long time since we've been there in person. And this is an auspicious occasion where we've been asked by the staff, we've been working closely with the rest of the finance team to put together the bones of a transaction that would help you do these first two major projects coming up on your long-term plan. And as Mr. Henry mentioned, it's a relatively small amount for this first transaction. We used to think 20 million was a huge amount of money, but at this stage, this is apparently what is necessary. I'd like to point out I'm here with my colleague as well. Graham Beck is on the line, and we've been helping put together the legal documents that are going to be coming up to the board in the future. And I think that is set for the 21st of March. And in the meantime, I'm going to pass this over to Gordon, who is going to talk about the basic outline of the transaction and what you'll be seeing in the paperwork that'll be submitted at the subsequent meeting. Gordon?
Thank you. And we have some materials.
1 second, Gordon, we'll get this up for you.
Thank you.
Okay.
If we could go up to the fourth page. There we go. Perfect. I guess just to start things off, just wanted to review, although Mr. Henry and Ms. Wells covered it as well, but review what we were financing and why we're financing it now. And in terms of what we're financing, as this slide indicates, it will be the pre-construction, that is architectural and development costs for the build out of undeveloped space in the Morris Hyman Critical Care Pavilion. And it will also fund the construction costs of the bridge connecting the hospital tower to this pavilion. And the financing will cover the costs of issuance as well. The rationale for doing it now, as Liesl indicated, this is a relatively small financing, but I think it's important because the $20 million, using the $20 million the financing will provide, will enable the hospital to maintain its unrestricted funds. And after all, this is the reason that the bond issue was passed. Second rationale for this is that we're able to do this at still very low interest rates. And this will enable us to really do the funding in a way that saves the voters and the members of the district money because of the lower interest rates. Currently, the average rate we would anticipate would be in the 3.5% to 3.75% range. And then I guess a third consideration for us going ahead now was this is a fairly straightforward issuance process, and we are hoping to have the financing completed by mid-April. That is the rationale for us going ahead. This next page indicates that it will only have a really nominal impact on residents of the district's property tax bills. The average will be for the average size taxpayer in the district, the impact will be about $4 per year over the course of the bond's repayment period. And then I guess the final detail I would provide is just on the next page, and that just indicates what our anticipated schedule is. We will be back with the board on the 21st for your consideration, final consideration of this bond issue. And if we have your support and approval at that time, we would plan to price the issue just before the end of March and have the financing closed and funds provided on the Wednesday, just on Wednesday the 13th, just before Easter. So that's what our plan is for this Series 22 general obligation issue. And I'd be glad to answer any questions or also offer Ms. Wells or Ed Wallab, our investment banker, if there are other questions.
All right, Madam President, it doesn't seem like there are any further questions.
Thank you very much.
Thank
All
you
right.
very much.
Thank you,
Thank you.
everybody.
Thank you very much.
Thank you. Bye-bye.
All right. We'll look forward to that coming back to us in April. Now we'll move on to our reports. Medical staff report. Dr. Hyder, our Chief of Medical Staff. Good evening.
Hi. Good evening to all. Thank you. Yesterday we had a general medical staff meeting. It went well. And in that we talked about Dr. Very sad to announce this, that Dr. Albert Asali, he recently passed. And we wanted to honor him posthumously as an honorary member of our staff. And we'll be doing that. And because he devoted about more than 50 years of his career for Washington Hospital. He was a urologist, and he was graduated from Columbia University. And then we are embarking on an important project which covers utilization and quality. We cannot practice without it. We have to justify to our payers so that our payment is done to our hospital as well as to the healthcare professionals. And Mr. Nick Watson gave overview of the clinical intelligence and its proposed timeline of 18 months. And it is targeted at case management as well as clinical documentation improvement. And he gave an overview, and we have to digest that. It was an excellent one, but it's something we are going to digest it. And the other thing is our medical staff manager, Angela, was finally given at least one day in a week to come back. Probably she will do it on Zoom. And we're really excited to have her. And at this time, our assistant manager, Jasparit, is helping us. The other thing is, after more than 2 years of COVID pandemic, finally, we are at a low threshold. The cases are low, and we are wondering what next. Although case numbers are dropping and we are feeling comfortable that we can able to treat this illness. Still, as this points, we know that the virus is very unpredictable and more variants are on the way. And how can we best learn to live with this virus? And the other thing is medical staff is very thankful to the administration in embarking on this important project of utilization and quality. Appreciate Ms. Hart's help all the time, as well as the board members. We appreciate that. We have a strong relationship with the medical staff, administration, and board members. This is my report for this.
Right. Thank you very much, Dr. Hyder.
Dr. Hyder, I just want to thank you for that wonderful news about Angela. That's really good to hear.
Thank you.
Really good.
Thank you, Dr. Nichols. Thank you.
We love that good news. All right, thank you. Next, our service league report from Debbie Feary, friend and
Hi,
colleague.
good evening. Greetings from all the volunteers. As you know, the Service League's fiscal year began March 1st each year, and we just held our annual meeting on February 18th. Over 40 volunteers joined the meeting via Zoom. We had it Zoom to be safe. We seated our new slate of officers for the upcoming year, and they are: the parliamentarian is Cherie Gamardo. Secretary is Diane Zariski, who's still the same. Treasurer is Sydney Margolis, still the same. Second VP is Gail Tamita, which that was the only thing that's really changed, is Cherie took the parliamentarian's position and Gail took what used to be Fee, her position as second VP. First VP is still Sheila Vijay, and I am continuing as president for another year. One of the priorities that we have this year is working on board succession planning and looking at how we can bring in new officers. In February, and getting on to the report, is in February, the total hours contributed by volunteers was 1,234. We had 54 adults and 26 college serving during the month. We also saw a huge decrease in the number of COVID-19 kits that were requested by the lab. In January, we assembled 3,075 kits. And in February, the number was down to 1,600. So it was almost half. The decrease obviously coincides with the end of the Omicron surge. Likewise, the number of vaccine syringes that we label declined from 1,451 in January to only 34 in February. So it was quite a huge drop. We want to thank you for all your support from the board of directors and the hospital. And you have all been welcoming us, and we've been getting into more, being able to volunteer in more places and help out. And we're looking forward to hopefully seeing more of us. And that's my report.
Very good. Thank you, Debbie.
Thank you.
Yeah, I was in the office yesterday and somebody from the ED was pushing a wheelchair with 2 huge bags of urine specimen cups and some labels or something, because they found a new project for the volunteers to do, to make put alcohol with the cups and put it in the bags. And so it's kind of nice that word is spreading that we're extra pair of hands to provide support during this time when our other services are kind of cut back. So they're finding new ways to utilize the volunteers, and that's always a good thing.
Yeah,
Freeze up.
Yeah, we're assembling urine kits.
Whatever we can do to help, that's part of our mission.
Yes.
Very good. Thank you, Debbie. Next, our quality report, Mary Boran, our Chief of Quality and Resource Management. We'd love to hear from you, Mary, what you have to share with us this time.
Thank you. I will be presenting our quarterly quality dashboard, and this will be for our quarter ending December 2021. So it will reflect data from October, November, and December. Getting into our first area is looking at our infection prevention indicators. On the next slide, thank you. This first one is MRSA, which is a very difficult infection to treat with standard antibiotics. And these are infections that are identified in a patient's blood 3 days after admission, and therefore considered hospital associated by CMS standards and definitions. We did have one this quarter. It's just only slightly below what would be expected for a hospital of our size and type. So it's, but it is still one MRSA infection. And we've been working closely with a multidisciplinary team looking at the MRSA infections to see if there's any opportunities to reduce the risk of transmission-based spread of MRSA, because it can be spread from transmission-based. So focusing on more of our hand hygiene efforts and making sure that we are not getting contaminated, blood cultures, et cetera, things like that are what our focus on. We have had pretty low numbers in general on this for the last 6 months, but nevertheless, one we do take seriously and even look into that further for a root cause analysis. And on our next slide, thank you. Catheter-associated urinary tract infections, otherwise known as CAUTI. We're happy to report we continue to see a decline on those. We did have one this quarter. It's about even or a little less than what would be expected for our benchmark. And this is an initiative that we've been working on for over 6 to 8 months now. We had a CAUTI Prevention Task Force, where a group of healthcare workers from a variety of disciplines have come together and really looked at making sure that our urinary catheters are only in place when they meet medical necessity, meaning that if a patient doesn't need a urinary catheter, the nurses do have a driven protocol that they can remove the catheter if the patient meets certain criteria for removal. That leads to a better timeliness of removal of the catheter. And if the catheter is out, the risk for developing the CAUTI is minimal to gone at that point. So really looking at medical necessity daily and making sure that the catheter only goes in when absolutely necessary, and when it is necessary to have it, that we're doing the day-to-day care for the catheter to reduce the risk of patients getting infection as a result of having their catheter. I think some of these efforts we're showing outcomes where it has decreased. Our actual catheter line days have gone down. And I think that typically is a great reflection of leading to lower CAUTIs, which we can see in this case. Mm-hmm. Our central line associated bloodstream infections, otherwise known as CLAPSIs, we've had now 6 months of great outcomes where we have not had a CLAPSI. This also is something that we experienced an increase in earlier in 2021, and we are working closely with nursing and the medical staff and infection control to make sure that we are also looking at medical necessity with these lines. The line days have come down. And again, this is a great outcome that reflects the work that that team has done. Yeah, it's great. Yeah. Our surgical site infections, there are procedures that we're required to monitor by the state of California and by CMS, and it's about over 35 procedures. We focus on the really high risk ones in this presentation, such as having surgery on your colon, which can make you at higher risk for getting an infection. And the general medical staff, general surgeon medical staff have had great outcomes with this for now 2 quarters in a row. We are at the second quarter having 0 SSIs related to colon surgery. It's great. And the same applies with our hysterectomies. This is another one that CMS monitors very closely. And we have actually had, as you can see, a continuous stream since 9 of 2020 without infections there. We'll continue to monitor that. And again, this is really a reflection of it's of course, it's the surgeon and the practice that occurs there, but it's also related to your OR maintenance, right? So how you turn over a room, how clean of our rooms are, and the practices that are put into place during surgery with sterile fields being maintained. And that really is a reflection of the whole surgical team working with the patient during OR and getting the patient good education on how to take care of the wound afterwards, et cetera. So another great success here with our abdominal hysterectomies. C. diff is another area that we have over the years experienced some challenges with, especially in 2020. And we've had another working group dedicated to that. And we are now at our second quarter where we are far below the benchmark. This last quarter, we did have 1 C. diff, which means that a patient had a positive lab ID for C. diff within 72 hours after being admitted. This is what they call just lab surveillance. It's not a clinical picture of the patient altogether. It's just that the patient did test positive. So if you test the patient for the first time after 72 hours, then and they're positive, it would be considered a hospital-associated infection. So what we've done is really in this working group is drilled down closely at making sure that we're testing patients appropriately. And our antimicrobial stewardship team really carefully manages our antibiotics and how we prescribe them in the hospital. And your C. diff infection is one of the outcome measures to a strong antimicrobial stewardship program. So the practices that we've done with testing and treatment of antimicrobial stewardship, I think has reflected here also very well with only 1 C. diff infection. Hand hygiene is probably the number one patient safety goal that we're working on this year with our patient safety officer, our chief of compliance. Kristen is leading patient safety on this initiative this year, really focusing on what can we do to get our hand hygiene compliance up further. Currently, we are at 83% this quarter, and while it may be above some World Health Organization benchmarks, it's still below what Joint Commission benchmark is, which is 90%. But here at Washington, we actually continually strive for 100%, mostly because this is the number one means of stopping the spread of infection from patient to patient. If we're all washing our hands appropriately, we decrease that risk of spreading it to one another as we work together and to our patients. So the team is using a tool from Joint Commission in which we have standards that we follow for all the observers in the hospital. The observers come from different disciplines and are trained in a standard format and do observations throughout the hospital. And some even have a further level of training that's called just-in-time coaching. And that group actually stops and does education with the person that they recognize is not performing hand hygiene appropriately. And what's good about that practice is in that conversation, we often get feedback about why, or have an opportunity to teach them about why they should have washed their hand in that circumstances. And because it's quite comprehensive, all the points that we expect hand hygiene, multiple points typically for each patient interaction, and before you enter the room and after you enter the room. So again, this will always be a patient safety focus for us, and we're striving to get above 90% even. Our nursing sensitive indicators are also and these are additional nursing sensitive indicators, where CLABSI and CAUTI are also nursing sensitive indicators, but they relate to infection control. So therefore typically we present them under that area, but we have other ones, like for example, our falls for patients. We are below the benchmark, which is a good outcome of a magnet hospital where we're expected to even have higher standards on nursing practice. Our falls were low. This is a reflection of 5 falls, but with the high census and the large amount of patient days that are in that is well below the benchmark. They were also minor falls, and a minor fall is defined as if a patient, minor injury, if a patient falls and has sort of a bruise or a minor abrasion, we have to apply ice or do some sort of steri strips. Those are minor falls. Of course, minor falls we still take seriously. Each one of those falls is followed up with a huddle to determine what was the risk factor that the patient fell. Typically in these cases, it was a patient either sitting up and eating, and then they tried to get up on their own. And most of these patients are over 80, or they were trying to get to the bathroom. It's confusing when you're used to being at home or another place, and then you come into the hospital and they're a little bit sicker, in bed for longer, start to lose some of that mobility. And it's always important that we continue to remind them to call. All these patients had a call light near them at the time, but it's we're dealing also with some dementia issues, etc. So one of the things that was been put in place for these falls is that trying to get a sitter for these patients when they fall, always moving them closer to the nursing station, etc., so that we can have prevention in place and continuous assessments on their fall risk under the benchmark. But our goal is obviously not to have any falls. Hospital-acquired pressure ulcers, people might often think of these as what's commonly termed as bed sores, or another nursing sensitive indicator that we look at. I'm very happy to report that this quarter, for the second quarter in a row, we have had 0 stage 2 hospital-associated pressure ulcers. In the current state of having a very high census, complex patients that are sick, dealing with COVID, dealing with healthcare workers being off with COVID, I just really want to emphasize what a great outcome this is. And the reason why it's a nursing sensitive indicator is because it is a reflection of how well do we maintain the patient's skin while they're here. If they can't rotate themselves, are we in there helping and repositioning them? Are we offering the best nutrition we can to prevent their skin from breaking down? What are we doing with the mattress? All these things we take into consideration to make sure they have the best mattress possible and that the repositioned is reflected here. And that did not change. That practice was held as a standard through these sort of trying times that we've had recently in healthcare. The readmission rates are definitely the most complex and challenging area that we have right now in quality, and looking at some of our outcome data for what happens to our patients after we discharge them. And what we did notice this particular quarter is that, well, 1 or 2 may be under a benchmark, but they all increase. So I want to talk a little bit about the fact that we strongly believe that there are opportunities for improvement in this patient population. While these patients are sick and can often be complex, there is always an opportunity to sort of roll up our sleeves and get to work on trying to figure out what can we do to prevent patients from coming back to the hospital. Because if a patient needs to be in acute care, of course, we treat them and we admit them to acute care. We do not want outcomes where patients come back to the hospital and we could have prevented it. So from a quality standpoint, there are many aspects on why that obviously is not a good thing. So I wanted to go through each one of the disease states and talk about some of the areas and identified opportunities for improvement in each of the conditions. Starting off with AMI, otherwise known as having a heart attack, we did have 5 patients come back out of the 29 index admissions, which means that in this quarter, 29 people left the hospital with a primary diagnosis of a heart attack, and then 5 of those patients came back within 30 days. This is above the benchmark. Of these 5 patients, there's some analysis that we've done on each one of them. The average age for these patients was 75. Most of them stayed for an average of 4 to 5 days. And one of the trends in this patient population of these 5 is that 3 of these patients left with home health. And home health is actually an area where we can improve our communication with home health agencies. The hospital has initiated what we call high quality networks, which means that we have developed partnerships with home health agencies and with skilled nursing facilities in which we look at their quality outcomes. Readmission rates is one of them. And we look at metrics and we discuss and agree to certain standards that need to be met in order to call them a high quality an HQN, a high quality network that we work with. In this particular case, we do have HQNs for home health, and I feel strongly that there's opportunities to improve communication, develop these policies better. For example, these 3 patients, I think the opportunity really was making sure that somebody on our transitional care team is talking to the home health agencies daily, even in the beginning. And the biggest risk factor for these patients, especially if they're coming back in less than 14 days, which these patients did, there's opportunity to improving our relationship and making sure that they're working with the patient if they become short of breath, if they're not compliant with the diet, if they didn't get a medication they need. We need to be holding the home health agencies accountable to make sure that those patients are having their needs met. So I think that's going to be the focus area for this population. As we move into pneumonia, this is by far the most challenging condition that we deal with readmissions. You can see it's been above the benchmark consistently, except for 9/21. And this quarter, we had 18 patients come back out of the 62 index admissions for pneumonia. So this is far above the CMS benchmark of 16.7. We're at 29%, which we've taken these 18 patients and done an analysis on them. Of these patients, their average length of stay was 8 days. Majority of them were actually over 80 in these cases. And I think often when we think pneumonia these days, the first thing we're asking ourselves is, oh, it must be COVID. In this circumstance, I will tell you it was not COVID. Only one of these patients came back or had an initial admission of COVID. So COVID is not the root cause of our pneumonia readmissions. But what we have found is when we look at these patients, the overwhelming trend is that they have multiple comorbidities. They have diabetes, they have hypertension, they have kidney failure. And those are complex patients, and complex patients need to have comprehensive discharge planning that needs to start the day the patient gets here. Epic has built us great readmission risk tools. These patients were identified as medium and high risk for readmission, which means that they should have had an assessment within 24 hours of admission. And I think we have opportunities to improve on doing that, to make sure that these patients are assessed within 24 hours of admission, which means that you start coming up with goals around expected discharge dates. Like I said, they stayed for an average of 8 days. That's plenty of time to get a comprehensive discharge plan in place. So if we are doing that assessment, we can identify issues that may come up with the meds. All of these patients have long, extensive med lists. That's one of the reasons why they were actually identified as medium and high risk for readmission initially. Between their comorbidities and their medications, social risk factors at home, etc. All of those things we need to start to plan for earlier in the stay and start communicating with the family members about the anticipated discharge date. So what do you need at home? What's assessing their understanding of medication? What is going to be the plan on getting the patient to their follow-up visit? These things I think could have started earlier in this patient plan, which really means effective discharge planning and effective care coordination, which will be one of our biggest focuses. We're working on a redesign here in the hospital with improving care coordination that I think will absolutely impact patients with pneumonia. The other thing with this patient population was when we identified that a patient has to go to a SNF, we need to have a start communicating with that SNF early on. And again, we have SNFs in our high quality network. I think we can improve how we communicate with those SNFs and the standards we hold, and even getting our providers more actively involved in communicating with us about the patients after they're discharged. Another thing I thought was interesting about these 18 patients is that 16 of them left with either home health as a support or a SNF. So that tells us that there is opportunity for improvement around those. These people did not go home with no support. They went home with a plan in a group that we can communicate and make improvements on. So I think that will be our focus. We also need to expand our physician leadership opportunities here to make sure that we have case managers have physicians, physician advisors that are trained and help them with managing the patients after they leave. And we can work with our medical directors and the SNFs on those. And I think that will be our focus area, because we do realize that pneumonia it needs attention, and it's our highest risk, as I mentioned prior. Moving into heart failure, very similar issues as with pneumonia. So 15 of the 75 came back. And while this does put us under the benchmark, it's slightly under the benchmark at 20%, and the benchmark is 21.9. Lots of reoccurring issues with these patients too. They're considered high risk because on average, they each had 4 to 5 comorbidities, polypharmacy, meaning lots of medication issues, very similar to pneumonia, with the exception of one thing I will say that we did notice different with heart failure is I think there was more of an opportunity here to have discussions about palliative care and hospice. It is not up to us in the organization to make that decision for the family or the caregivers or the patient. However, we do have a responsibility to present that option to them and let them decide so that they can make informed decisions for that stage in their life and the care. And there are opportunities to get palliative care referrals and hospice referrals into these patients so that they can have comfort at home and quality care and not have to keep coming back and forth to the hospital. I would say that that's probably one of the biggest difference I noticed when I was looking at pneumonia versus heart failure. So we'll be focusing on those resources around this case. And then moving into chronic obstructive pulmonary disease, otherwise known as COPD. This is another area where we did have 5 patients come back out of the 25. So that puts us at 20%, which is slightly above the CMS benchmark. COPD is have an average stay of 6.6. These 5 patients did. And again, this is an issue where 3 of them went to a SNF, 1 of them went to a home health agency. So again, same opportunities I mentioned with the prior disease states about working with our high quality networks. But the root cause about why they came back is a little different in the fact that we saw trends in fluid overload on these patients. So daily monitoring of the home health agency and communicating that with us to see if we can get some support with the patient while they're still at home or in their SNF about fluid management. And seeing what we can do to manage that outside of the hospital to avoid them having to come back is something that I think we is an opportunity for improvement in this area. There was one patient that did have an altered mental status, and we identified some areas for improvement around getting more support into the house for the patient. So again, I think it all comes back to communication and having standards and expectations that need to be met after discharge. Moving into our surgical groups, the coronary artery bypass graft, otherwise known as a CABG, is a heart procedure. We tend to do very well on this, as you can see. This was the first time we actually had a patient readmitted since our last quarter of 9/20. So well over a year, we've been able to sustain this. This particular case is absolutely necessary. This patient had a little bit of a flutter after being discharged, needed to be admitted, was on a drip for a couple of days, monitored closely, and went home after a couple of days and has been fine since. So this was a patient with diabetes and hypertension. But the point that I want to emphasize here is it was a medically necessary readmit and just for monitoring and safety of the patient that I find totally appropriate. Moving into our hips, this is another place where we do very well typically. It doesn't take much to make that line go through there. It's actually only one patient out of our 15. This are patients that have had a hip replacement or a knee replacement. We're still at 6.7, but the goal is to only have about 4% readmitted. In this particular patient, there were some just an unanticipated minor complication after the surgery. And again, they needed to be admitted and it was appropriate and not very typical at all for, we're still having great readmission rates since then on patients that have their hips and knees replaced. Our patients leave much sooner than anticipated. They have a very short stay, very low complication rate, and very rarely are they readmitted. So not so much concern here for opportunities for improvement. That concludes my report. Thank you.
Very good. Thank you, Mary. A lot to follow, a lot to watch, but I appreciate your diligence with looking for those opportunities to always improve, make things better for our patients. Thank you.
Yes, great. Thank you.
Very good. Okay. If there's no questions for Mary, let's move on to Chris Henry for our finance report.
Okay, thank you. Tonight we'll be going over Washington Hospital's operating and financial results for January 2022. And as always, we'll start with our acute inpatient statistics. Very busy in the hospital. Inpatient average daily census for the month was 36.3, higher than we expected in the budget at 178.7. Our combined average daily census, which includes our observation patients, likewise high, over budget by 37.8 at 187.4. Admissions for the month were 41 higher than expected at 894. Patient days were off the chart, 1,125 higher than expected in the budget at 5,539. Our outpatient observation equivalent days for January came in at 271. We expected 223. And our average length of stay for the month was 5.51. We had budgeted 5.17 for January. Looking at utilization, the case mix index for the month was lower than budget, but still very high at 1.680. We had 9 more deliveries in January than we expected at 114. Surgical cases came in 45 higher than expected at 406. Cath lab cases, however, were 21 lower than budget at 171. Outpatient visits were 559 below budget at 6,944. And the emergency room visits, again, very busy, 1,181 visits higher than expected in the budget at 5,154. Looking quickly at the details of our surgical and cath lab cases. Surgical cases, again, 45 over budget, largely driven by neurosurgical cases, joint replacement cases, and cardiac cases, all above budget, offset by our general surgery and other surgical cases that were 26 lower than budget at 165. In the cath lab, the unfavorable variance of 21, largely driven by our peripheral vascular and cardiac product lines being under budget, but that being offset by non-vascular and neurointerventional radiology cases that were a combined 14 above budget. Looking at productivity, our productive FTEs for the month, not surprisingly, seeing the activity in the house, 102.4 higher than budget at 1,380.8. Non-productive FTEs likewise were higher than budget at 217.9. So total FTEs for the month, 153.5 higher than budget at 1,598.7. Our full-time equivalents per adjusted occupied bed, however, which is our productivity measure, came in at 5.55 against a budget of 6.65, and I think that's reflective of some of the struggles we've had with staffing to this volume. Moving into the financials, first we'll look at our Governmental Accounting Standards Board presentation, which is the presentation used for our audited financials. Total patient revenue for the month came in $29.5 million higher than budget at $209,142,000. Our contractuals for the month, however, came in higher than budget at 79.26%. Quickly looking at the detail here, really that driven with our commercial and government payers. Payer mix for the month was not favorable. Government was slightly higher than budget. PPO was lower than budget, and HMO was higher than budget. HMO, the switch between HMO and PPO is not favorable to us. We have to contractualize those HMO accounts at a much higher rate. We also had a couple of high dollar accounts that we had to make some adjustments to the contractuals on, total of $1.3 million. The largest of those accounts is an account with a patient that actually was admitted in May of 2001. This patient's still in-house. At this point, they have an account in excess of $6.5 million. In December, we went to do an interim billing. This is a Medicare patient who was, when they came in, had eligibility for Medicare. We did an interim billing in December and discovered that the patient had used up all but 60 days of their lifetime days with Medicare. So that creates a whole chain of events that then once they've exhausted those days and once they're finally discharged and Medicare adjudicates the entire bill, then we have to go and bill Medi-Cal because they will cover a portion of that. And then once Medi-Cal adjudicates the bill, we can then turn around and bill Medicare Part B. But really what this results in is in much lower reimbursement for this patient. So again, those factors are what drove our contractuals up to 77.48%. For our insured patients, our uninsured patients came in pretty much as expected. So again, total deductions from revenue, about $26.4 million higher than budget. Okay, we're having a, there we go. So we end the month with net operating revenue that ended up at $4.7 million, higher than budget at $45,319,000. That $4.7 million, I want to note, includes an amount that is recorded in other operating revenue, not related to our insurance. The quality improvement program that's been implemented around the state when we budgeted this year was still in its developmental stages, and we had budgeted about $1.5 million to get from that program. Once all the dust settled in development of that program, we ended up actually getting $3 million. So we booked an additional $1.5 million in the month for that, which was gratifying. Moving into operating expenses were just under $4.4 million higher than budget at $44,808,000. As you would expect with the higher FTEs, our salaries and wages made up the majority of that. Salaries and wages were $3.2 million higher than the budget. We did, with our staffing issues, have to utilize a significant amount of overtime and double time to service our patients. So that really drove those numbers up. Benefits got a little relief from benefits. They were lower than budget by $462,000. We had our health and welfare claims were $250,000 lower than budget. We did receive a stop loss recovery in the amount of $500,000 from our stop loss insurance. Those two things were offset by our payroll taxes, which were $235,000 higher than budget with our higher salaries and wages. Supplies for the month were $1.4 million higher than budget, and again, this was activity driven. The biggest variance there was in our prosthesis that were $500,000 higher than budget, but we also had significant variances in our drugs, our PPE, gloves and gowns, reagents, orthopedic supplies. So again, $1.4 million unfavorable variance for supplies. Pro fees for the month were higher by about $210,000. That includes consulting being up about $287,000 related to the consultants we have here working with us on our processes and efficiencies here in the hospital. That variance was offset by our hospitalist costs, which were $61,000 lower than budget. Purchase services for the month came in $168,000 higher than budget, largely driven by our bed reservation fees of about $140,000. These are the beds that we have reserved in local nursing homes to help with patient flow and get patients in the correct setting of care. So we end the month again with operating expenses about $4.4 million higher than budget, and an operating bottom line at the hospital from a GASB perspective of $511,000, about $338,000 higher than the budget of $173,000. Non-operating, we did have a non-operating loss for the month of almost $1.5 million against a budget of $103,000 of income. Again, this driven by an unrealized loss of our investments of about $1.44 million. The hospital suffering the same impacts that the rest of us are with the volatility in the markets. But I do want to note again, this is unrealized loss, that it is an accounting entry where we recognize the change in value of our investments on the markets. It is not realized unless we sold all of our investments on January 31st, and we certainly haven't done that. So something we have to recognize, but have not realized. So we end the month with a net loss from a total bottom line perspective of $987,000. We had expected income of $276,000.
Chris, can I ask you about the contractuals?
Yes.
Yeah, so this actually is a little surprising to me. And I'm wondering, was this COVID related, or is this a change in our payer mix? And probably the most important question is this going to persist with this?
No.
I mean, we haven't been close to 80% before.
Yeah. No, again, these were some additional contractuals we had to make based on the change, particularly in this one patient, in their insured status. 60 days of payment against, the patient's been here about 8 months now. We really needed to beef up the contractuals to accommodate the fact that Medi-Cal is going to pay some of it, but at a much lower rate than Medicare, and likewise Part B will pay some of it, but again at a lower rate. So these are one-offs. We do have several other long lengths of stay here in the hospital that we're looking at closely, but these are things that are in the normal course of business. It just kind of piled up this month.
Are we seeing a shift from straight Medicare to Medicare Advantage HMO?
Yes.
How difficult is that going to be for us?
Well, it depends is the answer, and for the most part, we get almost as much as Medicare, sometimes more, sometimes less, depending on the HMO. Likewise with the shift with Medi-Cal HMO, sometimes we do better with the Medi-Cal HMOs because we can negotiate those rates than we do with straight Medi-Cal. So it goes both ways. It cuts both ways, Dr. Nicholson, I guess is the answer to your question.
So it does mean more work to try to tweak the contracts or negotiate more effectively.
Yeah.
Thank you.
Okay. Okay, so moving on to our Financial Accounting Standards Board presentation. This includes adjustments that the financial markets might make to those GASB statements when they're looking at us. First thing they would do is reclassify the interest expense on our revenue bonds of about $572,000 out of the non-operating category up into operating expenses. And that would create operating expenses of $45,380,000 and an operating loss. Flip that slight gain to a slight loss of $61,000. The next thing they would do, FASB does not recognize our GO bond interest expense and the related tax revenue, and they would eliminate that unrealized loss on our investments because they look at it differently. To end up with non-operating income instead of a loss of about $231,000. So we would end up from a FASB perspective with about $170,000 positive income on the bottom line against basically break even from a budget standpoint. Quick look at earnings before interest, taxes, depreciation, and amortization. Again, this is a way to look at our financials. This is based on our GASB format. This is a way to look at our financials to see how much income they are generating beyond just our operations for other expenditures. First thing we do is we pull our depreciation expense, which is a non-cash transaction. It's actually the recognition of cash flow that's already occurred in the past. And we end up with EBITDA of about just under $4.4 million for the month of January. The next thing we do is go and look at our non-operating income before we pay interest expense. That adds another $230,000 to that number. So in total, Washington Hospitals operating and non-operating activities generated about $4.6 million for the purpose of paying the interest on our bonds, as well as capital expenditures and program development and other things. So are there any questions on January? Okay.
All right, then I will go on to February. It continued to be a busy month in February, not quite as busy as January, but you'll see that it was. In terms of looking at the preliminary gross revenue of $194.5 million for February was above budget by $24.8 million or 14.6% and above February of 2021 by $27.1 million or 16.2%. Inpatient gross revenue of $123.9 million was above budget by $8.6 million or 7.4% and $12 million or 10.8% above February of 2021. Although admissions were down, average length of stay and patient days were significantly higher than budget. Inpatient surgery and cath lab cases were also higher than budget, which you will be seeing. In terms of outpatient gross revenue of $70.7 million was above budget by $16.3 million or 29.9% and $15.1 million or 27.2% above February of 2021. Just to put it in perspective in terms of our COVID, in February we had 130 COVID-19 discharges, representing 16% of total discharges, which was 787. This represents a decrease from the prior month of 193 COVID-19 discharges or 23% of 859 discharges. So not as many COVID patients that were discharged during the month of February. Moving on to key statistics. First of all, average length of stay of 6.38 was above the budget of 5.36 by 1.02 or 19%. but lower than February of 2021 average length of stay of 6.83 by 0.4 or 6.6%. You can see our outpatient observation days of 288 were above budget of 166 by 122 or 73.5%, and 99 or 52.4% above February of 2021. Our inpatient average daily census of 178 was above budget of 153.5 by 24.5 or 16%, and 23.9 or 15.5% above February of 2021. If you're looking then at our combined average daily census of 188.3 was above budget of 159.4 by 28.9 or 18.1%, and 27.4 or 17% above February of 2021. The average length of stay for the 130 COVID-19 patients discharged in February was 8.80, which is higher than the overall average. In February, there were 11 discharges with length of stay greater than 30 days, ranging from 31 to 117. If you excluded those 11 discharges, our average length of stay was at 5.71. As Chris mentioned, we still have in-house at the end of the month, we have 15 patients with length of stay over 30 days, and they range from 31 days all the way up to 280 days. So we still have a number of patients that have been in-house for quite some time. Moving on to our admissions trend, our admissions were below budget by 38 or 4.7%. Admissions for the month were 81 or 11.9% above of February of 2021. 9% or 15 cases of the total joint replacement cases were inpatients, compared to 36% budgeted or 48 cases, which is a difference of about 33 admissions. Moving on to our patient days, admissions were below budget as mentioned, but our average length of stay was higher than budget by 19% or 1.02. This resulted in patient days of 4,985, which was above budget by 686 or 16%. Our patient days for the month were 670 or 15.5% above February of 2021. We had a good surgical month. Our total surgeries in February of 392 were above budget by 83 or 26.9%. Surgeries were 76 or 24.1% above February of 2021. Our inpatient surgeries of 163 were 18 or 12.4% above budget, and 28 or 20.7% above February of 2021. Outpatient surgeries at 229 were 65 or 39.6% above budget, and 48 or 26.5% above February of 2021. I will just once again remind the board that we did budget for outpatient joint replacement cases to begin migrating to the Peninsula Surgery Center towards the end of 2021, but we're still pending accreditation at the surgery center in the Peninsula Surgery Center. So probably we'll start to see that migration more in the next number of months. All right, in surgical activity, just the breakdown, our joint replacement surgical cases were above budget by 27 or 20.5%. and were 26 or 19.5% above February of 2021. Our neurosurgical cases were above budget by 3 or 10.7% and were 9 or 40.9% above February of 2021. Cardiac cases were above budget by 10 or 200% and were 1 or 6.7% above February of 2021. And all other surgical cases combined were above budget by 43 or 29.9% and were 40 or 27.9% above February of 2021. Cath lab cases also were favorable. We could see that cath lab cases for February at 216 were 11 or 5.4% above budget, and 18 or 9.1% above February of 2021. Cath lab inpatient cases at 117 were 6 or 5.4% above budget, and 2 or 1.7% above February of 2021. Our cath lab outpatient cases were 99, were 5 or 5.3% above budget, and 16 or 19.3% above February of 2021. Now looking at the breakdown of the cath lab activity, cardiac cases were below budget by 19 or 19%, and 5.8% below February of 2021. Non-vascular interventional radiology cases were above budget by 19 or 38.8%, and 30.8% above February of 2021. Peripheral vascular cases were above budget by 9 or 17.6% and 3.4% above February of 2021. Then lastly, our neurointerventional radiology cases were above budget by 2 or 40% and 250% above February of 2021. All right, moving on to our deliveries, which continue. We've seen deliveries of February of 88 were below budget by 20 at 18.5%, and the deliveries were 4. If you can hear the chimes in the background, there was just a baby born. I thought it was very appropriate. Deliveries were 4.3% below February of 2021. We are trending back up for March. I know February of 2021 was also low. It also just knowing that February was a shorter month too in terms of the days. So we should be seeing the trend going back up. All right, moving on to non-ER outpatient trend. Our non-ER or non-emergency outpatient visits of 7,047 were above budget by 199 or 2.9%, and were above February of 2021 by 491 or 7.5%. This is preliminary. This is primarily driven by lab visits at 2,590, which were below budget by 4.3% and 8.6% below the prior year. Also, hyperbaric visits at 129 are above budget by 70 or 118.6%, and 87 or 207.1% above the prior year. Also, cardiac rehab visits at 605 were above budget by 201 or 49.8%, and 272 or 81.7% above the prior year. And as mentioned previously, we are slowly getting back up, but not quite there to our pre-COVID average number of visits per month. All right, moving on to our emergency room. As you know, January was extremely busy, one of the busiest months. February was still busy, but not quite as much in terms of our emergency room visits. We saw 3,855, which was above the budget by 307 or 8.7%, and 778 or 25.3% above the prior year. Just to sort of put it in perspective, there were 75 COVID-19 ER visits in the month of February, compared to 803 COVID-19 ER visits in the month of January. So very much started to see that we were on the other side of the surge in February. All right, moving on to our gross revenue recap. Cath lab cases were above budget by 11 or 5.4%, and there were more inpatient cases, driving revenue up 901,000 or 7%. Deliveries were below budget by 20 or 18.5%, and we had fewer C-sections, driving revenue down by 663,000 or 23.2%. Our emergency room visits were above budget by 307 or 8.7%, and acuity was higher, driving emergency room revenue up by 1.2 million or 12.6%. Our patient days were above budget by 686 or 16%, driven by medical surgical areas and medical oncology, resulting in 5.2 million or 15.1% above budget. Total surgeries were higher than budget by 83 or 26.9%, driving surgical services revenue higher than budget by 8.3 million or 26.6%. Lastly, our inpatient and outpatient activity drove ancillary services revenue above budget by 9.9 million or 12.6%. All right, so moving on to our payer mix. Government-sponsored patient revenue made up 74.6% of total gross revenue. This is higher than the budget by 1.5% and higher than the prior year by 2.9%. HMO was 1.3% of gross revenue, which was below budget of 2.6% and lower than the prior year percentage of 2% of gross revenue. Our PPO was 22.6% of gross revenue, which was slightly above budget of 22.4%, but lower than prior year percentage of 25.2% of gross revenue. And then lastly, our private pay was 1.5% of gross revenue, which was below budget of 1.9%, but higher than the prior year percentage of 1.1% of gross revenue. All right, so moving on to our productivity indicators. Productive FTEs were above budget by 162.8 or 12.2% at 1,497.9. Non-productive FTEs were above budget by 32.3 or 19.1% at 136.6. Our total FTEs of 1,634.5 were above budget by 130.5 or 8.7%. So again, you see how busy we were and the need for the productive FTEs. Looking at our metrics that demonstrate productivity, our productive FTEs per adjusted occupied bed of 5.36 was lower than the budget of 5.91 by 9.3% or 0.55, and lower than the prior year of 5.84 by 8.2% or 0.48. Our total FTEs per adjusted occupied bed of 5.85 was lower than the budget of 6.66 by 12.2% or 0.81, and lower than the prior year of 6.59 by 11.2% or 0.74. So again, had a pretty good month in terms of productivity. But again, it's as mentioned, it's been difficult in terms of with staff and having to do a great deal of overtime and double time. Looking at our preliminary outpatient statistics, our Whitman clinic visits were below budget in February by 77 or 0.5% at 16,021 and were 196 or 1.2% below February of 2021. Our DevCo outpatient visits of 2,134 were above budget by 82 or 4% for the month of February and 83 or 4% above the February 2021 visits. Our Washington Outpatient Rehab Center was above budget by 105 or 8.5%. If you remember, we did bring on some additional staff in January, and you can see that that has helped. Our Washington Radiation Oncology Center treatments were down 17 or 4.9%. Our Washington Outpatient Surgery Center was above budget by 34 or 7.8%, and this was primarily driven by an increase in gastro cases and also gynecology cases. And then lastly, our Ohlone College Student Health Center was down 40 visits or 78.4%. It has remained closed. As you know, most of Ohlone College has been, classes have been done virtually, but it is our understanding in March that they're going to start to bring back more on-site classes. So we should hopefully see some of the volume come back to the Student Health Center. All right, and lastly, in terms of our key financial statistics, Our days cash on hand for February ended at 158 days, a decrease of 1 day from last month due to a number of factors. The first, we sent a $1.4 million matching contribution to the state for the direct municipal public hospital quality incentive pool. We expect to get $5.4 million in April after federal matching funds are applied. We also had to fund $2.8 million into the Warm Springs Health Center Partnership LLC as the district's 51% share of initial working capital contribution. That represents about 3 days. There are fewer collection days in February, and investment losses during the month resulted in a net impact of approximately 2 days. And this was offset by the Hospital Quality Assurance Fee, the HQAF payment, which we received of about $5.5 million, or 5 days. Moving on to our days in accounts receivable as of February 28, were 69, a decrease of 1 day from the prior month. There were fewer work days in February, but collections were sufficient to drop AR days by 1, and I know as of today we're at 68 days. So we're continuing to make progress. And then lastly, there were $146,000 in charity care adjustments in the month of February. Are there any questions? All right, Madam President, I'll turn it back over to you.
Okay, and then I'll turn it back over to you. As we move into action items,
Okay.
there are 3, and Kimberly, I'll have you go ahead and share your opening comments if you want to start with the first one, potential parcel tax.
Yes, thank you very much. I will begin with action item A. Hold on 1 second. All right, I want to just remind the board that at the February 23rd, our last meeting, 2022, the board directed staff to further research and prepare a potential draft of a parcel tax measure. In order for us to accomplish that, I did engage a law firm who has a lot of experience in this area, and that is of Olson Remco, to help to advise the district in the preparation of the process of understanding the process and the preparation of a potential parcel tax measure. So I've invited this evening, as you can see, Benjamin Gerverser. He is an associate attorney at Olson Remco LLP. And let me just give you a little bit about a background about him, and then I'm going to have him just really walk through the process if we were going to go down this path, and then also talk about a draft parcel tax measure. So to begin with, Benjamin Gerverser represents clients in litigation over election law, public policy, and constitutional issues. He also advises clients on political and government law matters, including drafting complex ballot measures at both the state and local level. Prior to attending law school, Mr. Gerverser worked on presidential campaigns in Pennsylvania and North Carolina, and at the California Department of Finance on issues such as 2011 public safety realignment, public safety funding, and the economic review of regulations. He has authored and co-authored articles on the initiative process and California's fiscal constitution, published in the University of Southern California Law Review and with the California Constitution Center. Benjamin is a graduate of University of California, Santa Cruz, BA cum laude, and University of California, Davis School of Law. He was admitted to the California Bar in November of 2018. All right, Benjamin, I will turn it over to you to sort of go through the memo that you had wrote on the process and the draft parcel tax measure.
Thank you, Kimberly. And can everybody hear me?
Yep.
Okay,
Yeah.
Great. Thank you for the kind introduction. Again, my name is Ben Gerverser. I'm an attorney with the law firm of Olson Remco, and our firm was retained to assist in drafting a parcel tax measure for the district. And so my goal tonight is to provide a short overview of the process for placing a measure on the ballot, and to talk a little bit about the measure we've drafted. So to begin, the California Government Code authorizes the district to impose a special parcel tax on all real property within its boundaries. And the main rule for this is that the tax must apply uniformly to all taxpayers within the district or to all real property within the hospital district. And there's also several statutory requirements for all tax measures regarding the spending, accounting, and oversight of the tax revenue. And so with that in mind, we've drafted a parcel tax for the Board of Directors consideration, and that's attachment 1. And so the measure would impose a $98 special parcel tax on each taxable parcel within the district. And the parcel tax could be adjusted each year by the Consumer Price Index for the Bay Area, but it couldn't be adjusted over 3%. And so the revenue for that tax would go into a special fund, and it'd be used for a couple purposes. First, the continued operation of the hospital and other hospital facilities in the district, including the operation of the emergency department. And second, for trauma and life-saving medical equipment, disaster preparedness, public health, emergency preparation, operating technology, and diagnostic imaging technology. And finally, the measure would have an annual audit. Excuse me, sorry about that. And the CFO must file an annual report about the revenue and spending each year. And so with that, the board can take 3 of the following steps. First would be to direct staff to return with a resolution to place the parcel tax on the ballot. And the second would be to hold off and table a vote on the parcel tax. And this is because the district has until August 12, 2022 to place a tax on the measure. So the district could further study the issue. And the third option would be to decline to put a parcel tax on the ballot at this time. And so if the board decides to move forward, there's a couple steps that the board needs to follow. First, the board would need to approve a parcel tax with a 2/3 vote, and then call an election to place the parcel tax on the ballot before the district voters. And if the district does put that measure to a vote, the measure would have to be approved with a 2/3 vote at that election. We just want to note there's an alternative path where district voters can propose a special tax initiative by the initiative petition. And there are recent cases that California courts have made clear that when local voters are acting using their initiative power, they can adopt a special tax with only a simple majority vote. And so under this process, which is outlined in the election code, the proponents and voters in the district would have 180 days to collect signatures to qualify the measure. And if they had those sufficient signatures, the board would put that measure to a vote. And so under each of these options, the board would consolidate a parcel tax election with an upcoming election. To do so, you have to do so by at least 88 days before the election. So as I mentioned earlier, that's August 12th of this year. And so with that, the board would call an election and submit information to the Board of Supervisors who will help run the election. And so with that, I'll turn it back over to Kimberly, and I'm happy to take any questions about the measure or about this process.
Does the board have any questions for Benjamin about the process, or as you mentioned, the draft of the parcel tax measure?
I don't have any questions, but I wanted to thank you, Kimberly, for securing the analysis provided by Olson Remcho to help guide us in this matter, and looking at the various options that are proposed in the analysis. I think the best option for us at this time is to continue to study the matter.
Mm-hmm.
I agree.
Yes, as written in my memo, that is my recommendation, given that a decision does not have to be really made until the end of July, beginning of August. My recommendation is for us at this point to put it to continue to we have the time to continue to study and bring it back to the board at a later date.
I appreciate that. Your memo's very clear. I appreciate what you've put together for us, Ben. Is there any other discussion on this action item? Then may have a motion for the consideration of the potential parcel tax.
Madam President, I hereby move that we hold off placing the tax measure on the November ballot. Further, we direct staff to continue to explore and study the matter as circumstances evolve and report back to the board by end of July.
Very good. Thank you, Dr. Eapen. Is there a second?
A second.
Thank you, Dr. Nicholson. Roll call, please, Dee.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace, Director Eapen,
Aye.
Director Nicholson.
Aye.
Thank you very much. So that motion passes. We appreciate your input on that, Ben. Thank you again. All right, Kimberly, do you want to move ahead to action item B, the resolution of 1238?
All right, thank you. I'm actually requesting at this point, in terms of the consideration of resolution number 1238 in the joint venture with UCSF, that the board does postpone this action item for a future meeting. There are still some pieces that are being worked upon. So I would like, and my understanding is we don't need to take any action or anything at this point. Correct, Paul?
Yes.
Yeah.
Very good, that's fine. I know there's a lot of moving pieces to that. So we will postpone that, take no action on that. Let's move to action item C, the consideration of resolution 1237.
Yes, Madam President. So this is requesting revisions to the asset allocation for the retirement plans, and to add the basically private credit asset class to the portfolio for both the pension plan and also for the post retirement plan too. So for both plans. So we have a resolution which encompasses subscription agreements and other pieces.
Okay, were there any questions on the information that was posted? Any other discussion?
Just, I think it's good that we're have the opportunity to expand our options.
Yes.
All right, then, may I have a motion on that action item C?
Madam President, in accordance with the district law policies and procedures, I move that the board approve the revision to asset allocation in the district's retirement plan and other post-employment benefits and approval of subscription agreements.
Thank you. Second?
Second.
Thank you very much. Roll call, please.
Director Yee,
Aye.
Director Stewart,
Aye.
Director Wallace, Director Eapen,
Aye.
Director Nicholson.
Aye.
Very good. Thank you so much. That motion passes. All right, next announcements, Kimberly.
I do have a couple of announcements, and I'd like to start with Employee of the Month for March 2022, and it's Mrsa, and she is a certified nurse assistant on 6 West. Certified nursing assistant Mrsa came to Washington Hospital in 2012. Working as a nursing assistant seemed like a natural fit for someone who was accustomed to helping others. In her native country, Ethiopia, Mrsa worked as a social worker. At Washington Hospital, she started as a per diem staff member, but Mrsa was anxious to become part of the hospital family. In 2015, her wish became a reality, and she joined our staff with a full-time role. Working on 6 West, Mrsa works with many patients, helping them to get up and walk, or when needed, helping them to eat or bathe. As a certified nurse assistant, Mrsa knows she is both helping patients and our nursing staff. She finds her work extremely rewarding. Jocelyn Lev RN says we can always count on Mrsa to help with call lights and safely care for our patients on 6 West. Mrsa precepts new hires and leads by example as she exemplifies our patient-first ethic. Nurse manager Lauren Lucas notes that Mrsa is often found walking the floor and engaging with patients, generally going the extra mile when it comes to patient care. She treats each patient with individualized care and concern. Living in Fremont, Mrsa and her husband raised twin 18-year-old boys. They are currently in their first year of college. On her days off, she enjoys hiking on Mission Peak or the Dry Creek Trails in Union City. We are all very proud to recognize Mrsa as our March Employee of the Month. Yes. All right, I just have a couple of other announcements. I just want to let the community know that the community vaccination clinic has moved outside Washington West to the COVID testing tent. So we're still scheduling vaccinations for individuals aged 5 years and older. Also, as of Friday, March 4th, a total of 86,069 COVID vaccine doses have been administered to community members at our vaccination clinic. This represents all first and second doses, as well as third dose booster doses. The total number of people who have received a COVID vaccine is 42,439. Additionally, 15,920 boosters have been administered. And we're also, as I mentioned, continuing to vaccinate children ages 5 to 11 years old. Moving on to some of our education, on Thursday, February 17th at 6:30 p.m., Dr. Brian Bonner, orthopedic surgeon with Washington Hospital Institute for Joint Restoration and Research, presented Advances in Joint Replacement Surgery on Facebook Live and YouTube. We had 146 community members participated in the live event, and since then, 351 additional people accessed the presentation on one of our social media channels. Then on Wednesday, February 23rd at 3:30 p.m., Dr. Stephen Catalia, infectious disease specialist with Washington Township Medical Foundation, presented COVID-19, What Families Need to Know on Facebook Live and YouTube. 187 community members participated in the live event, and since then, 470 additional people accessed the presentation on one of our social media channels. On Wednesday, March 2nd at 6:30 p.m., Sherry Gent, yoga instructor with the Washington Hospital Wellness Center, presented Improve Your Balance with Yoga on Facebook Live and YouTube. 153 community members participated in the live event, and since then, 220 additional people accessed the presentation on one of the social media channels. Then on March 22nd at 6:30 p.m., Dr. Mark Hsu, urologist, will present Overactive Bladder Causes, Symptoms, and Treatment on Facebook Live and YouTube. I think you can see that we have quite a bit of participation on our social media channels and Facebook Live with our community education. Then lastly, I do want to announce that Foundation is preparing to host the 35th annual golf tournament on the Hill course at Castlewood Country Club on Thursday, May 5th, 2022, in support of surgical services at Washington. Registration begins at 9 a.m. with 11 a.m. shotgun start and a post-tournament cocktail reception from 4 to 5 p.m. And I believe you can register on our website. All right, those are my announcements.
Very good. Do we have need for a closed session this evening?
We do not.
Okay. Well, there being no further business, we will adjourn this meeting and let you enjoy the rest of your evening. Thank you, everyone, for your participation and input. Have a good evening. Thank you.
Thank you.
Thanks. Good night.
Bye.
Good night.
Night, everybody.